Robyn Milton. Robyn began her healthcare career in pre-hospital emergency medicine and discovered a passion for teaching as an ACLS instructor. She now runs a Cape Town GP practice focused on serving neurodivergent and alternative lifestyle communities. Her special interests include sexual, hormonal, and metabolic health, and she is passionate about providing sex-positive, queer-friendly, and affirming care for all genders. Welcome, Robyn. I'll hand over to you.
Thank you, Cohen. All right. So, hi, everybody. Thank you so much for coming. Just going to share this screen. All right. Working as planned, Karen. Yes. Okay.
Yes, we can see.
So thank you. So I'm just going to start with essentially some disclaimers. So what I have really done is try to sort of reframe how we're going to approach perimenopause and really get into it. My talk is mostly informed by the International Menopause Society guidelines, but as you can see, the evidence there is lacking in that guidelines haven't been updated with the latest evidence, really. All right. So a reminder that I am not a menopause specialist. I don't have any postgraduate qualifications or degrees in this. I am basically just an autistic nerd who had a special interest because I saw that this was happening to all of my friends and to my clients. And that's why I have also dedicated this talk to my patients who have really taught me the most that could possibly have been taught. Particularly one of my first patients when I started working as a GP who came in, a 40-year-old woman with a frozen shoulder, and told me, you know, could this be perimenopause? And I had no idea what she was talking about. And through her and through subsequent patients is how I really learned about how to manage perimenopause. I think a very important part of discussing all of these things that we're going to discuss today is talking about the privilege to access individualized healthcare. So the medications that I'm going to be talking about are not currently available in state. They're not available on the EML. This kind of thing, you know, if you're working in state, you might not be able to access this, and the majority of the clients that I work with are able to access it through private medical aid or through their own funding, and I think it's just important to acknowledge that in South Africa particularly. And very important, you know, people ask who treats perimenopause, and the people who treat perimenopause are primary healthcare practitioners. So a lot of patients will come to say that they went to go see their gynaes or their obstetricians and had sort of bad experiences there. There is no reason why perimenopause or menopause needs to be a specialist subject. 51% of the South African population is going to go through this at some stage. And so we all need to be able to recognize and support these patients, and also for ourselves as well. Essentially, the most important part of this talk is going to be saying that menopausal hormone therapy is an extremely low risk and high benefit intervention that drastically improves the quality of life and the burden of disease. And it is one of the most rewarding things to treat because patients will come and sit in front of you and feel like their lives are falling apart. And you prescribe a menopausal hormone therapy and you see them 3 months later and they tell you that they are feeling the best they've ever felt in their lives. So it's incredibly rewarding. Just to declare, I am not funded by any big pharma or big supplement or big gym companies at all, unfortunately. But no AI was used in this presentation because it is terrible. All right. All right, so I thought I would start this conversation by using a case study. So we are sitting in our office and we are presented with a 38-year-old cis woman. She has a history of PCOS, which we now know is actually called PMOS, and she is also ADHD, so that just means she has co-occurring autism and ADHD. She has no other medical significant surgical history. She presents to you, she says, with worsening insomnia. For the last 3 months, she's gotten into bed and laid down and just felt like she was ruminating, becoming very anxious, unable to sleep. And she also notices that her PMS symptoms have gotten worse. You know, she can tell when she ovulates according to her period app, but the sort of next day or the day after, immediately she notices a dip in her mood and her energy, and her anxiety becomes really bad during her luteal phase. She feels just like her wheels are coming off. She thinks it's probably just stress. She's very stressed at work, you know, she's managing a relationship and so on, but she thought maybe just check to see it's not a medical problem. So when we have a patient like this who is 38, we're not normally thinking about menopause and perimenopause, and that is because of the current framing of perimenopause. And this is done by this figure. Some of you might recognize it is called the straw 10 diagnostic table that comes straight out of the International Menopause Society guidelines. And so this was what people would use to say, okay, how are we going to diagnose patient who is menopausal? How do we look at that? But you'll see in this table that IMS has made, there are actually no ages here. So they haven't put any ages down. And you'll see under duration, it says variable the whole time. So reproductive is variable, perimenopause is variable, and there are really no factors that we can put down, sort of on paper to say, this is the beginning of perimenopause, this is the beginning of menopause. And so this was not particularly helpful, essentially. And also the way that they decided to talk about this was they would say perimenopause only starts once you start to have menstrual changes. So that was kind of like the symptom that was most important. But if you go and read the latest guidelines from the IMS, and you'll know, you might know, if you go into IMS, you can get their whole guideline. It's 282 pages. I have not read the whole thing. There is also a summary that was made by this African Menopause Society, which is 24 pages, which you can get for free on their website, which is very helpful. But after this, this table where they talk about diagnosis, they actually have a bit of a summary or a bit of a chapter that says they acknowledge that there have been a huge amount of new evidence that's come out to show that this is actually incorrect, essentially, and that they do not know, they cannot say for certain when perimenopause actually starts or how to go about diagnosing it in terms of age. So that is kind of their position statement, and they're saying that we know that soon there'll be more evidence, more data, and they'll be able to give better guidelines. So what they have been saying is that menopause is defined as when we have not had a period for at least 12 months. So that is the actual definition of menopause. It is basically one day in time. You're only in menopause that one day when you haven't had a period for 12 months, and it's a retrospective diagnosis. And we used to say that early menopause was someone whose period had stopped between the ages of 40 and 45. The average age, we've always been told, is 51, but that is very specifically in white women from high-income countries. And the straw 10 diagram, which I spoke about earlier, the table that we looked at, that is all from data from high-income countries. There is some old studies that show that African women tend to go into menopause quite earlier, at around 48, but it can be highly variable depending on the person's genetics and their environmental and lifestyle factors. So what we used to say, like I said, we said perimenopause started when there were menstrual changes only. However, now we say there's new evidence that emerged that we don't know when perimenopause starts, and that other symptoms most likely occur well before menstrual cycle changes. So a number of studies have exhibited that symptoms can start far before anything happens to your periods. And there was a massive study that was done, and this is what's so interesting about the time that we live in at the moment, is that studies and evidence and data is being collected in a very different way from how it was before. It's not coming from only sort of institutions of academia like universities, but it is being democratized. So the Balance Group is a group that was started in the UK by Dr. Louise Newsom, and she started an app. So you can go onto your phone and you can download the Balance app, and it's essentially an app for perimenopausal women to track their symptoms and to track their cycles. And they managed to do a study in that they enrolled 447,000 people on this app, and they asked these people to document their symptoms and then give consent to use that data. And so now we have essentially what is the biggest study that's ever done on perimenopausal women. And they found that the symptoms that were most prevalent in these patients had nothing to do with menstrual cycles. There was also a study that was released very recently, I think in the last month, done in women with ADHD, and they found that symptoms started actually almost peaked in the ages between 35 and 38. And this isn't because women with ADHD have more sort of erratic hormones, it's because they're more sensitive to their internal environments. They have neurosensitivity to the changes of estrogen and progesterone. So it actually infers that everyone. So neurotypical women also have symptoms or start having perimenopausal then, but they might just not be sensitive to them. They're not picking them up. So this was a very sort of groundbreaking study at that time. And we also know that from further studies that in African women, symptoms can appear at least 10 years before menopause. So if we say that someone is going into menopause at the age of 48, it is very feasible that they can start having symptoms of perimenopause at 38, which would have been much younger than we would have thought. So really what we should be doing is reframing that every time we see a cis woman in our office, and they are at least sort of over the age of 35, we should actually be screening for perimenopause in these patients. I just briefly want to mention primary ovarian insufficiency, which is essentially a disorder where you stop having a period very early. That is very different. But what we're looking here is not necessarily menstrual cycle changes early, but the other symptoms. So primary ovarian insufficiency should be worked up, essentially. So essentially what we want to do is we want to believe women when they tell us that they have symptoms, which is really the change that we want to start seeing. And we know that menopausal hormone therapy is a preventative intervention. So we've seen multitudes of studies that have come out to say that it prevents osteoporosis, it can prevent certain cancers, it can prevent cardiovascular disease, and that prolongs quality of life and lifespan. And they far outweigh the risks. So the problem was a study that was done in 2002, which I'm sure you might have heard of, which is the WHI study. And that study was very poorly done and very wrongly interpreted to show that menopausal hormone therapy was dangerous and caused cardiovascular disease or caused heart attacks in women. But the problem was the type of menopausal hormone therapy that they used, and also the patients who had very intense risk factors, and they were all over the age of 60. So that is just something that we need to look at. All right. Okay, so in our patient now, what we want to do is we want to see, does this patient have any symptoms of perimenopause? So she's come in complaining of insomnia and worsening perimenopause or PMS symptoms. So we should do at least a screen. And obviously it's part of our history taking. We would do a screen for any other medical condition. But this should be part of it. And you can see this sort of the right-hand side, that screenshot, that is my perimenopause screening tool that I use on my laptop when I'm going through patients. So it's just a reminder of the groups of symptoms to go through. And then if the patient has maybe 2 or 3 of those groups of symptoms, it would prompt me to think this is where we're going in terms of perimenopause. So that Balance app study of 447,000 people that I referred to earlier, they found this top sentence. These were the most common symptoms. So fatigue, insomnia, difficulty with word finding, irritability, and anxiety. Those were the ones that over 90% of women reported on the onset of perimenopause. Loss of interest in sex was the one that they found was the most distressing. So about 80% of women experienced this, and they found it very distressing to their lives. And then a multitude of things, and essentially you can think about all the places in the body that have estrogen receptors. So I learned very recently that our eyeballs have estrogen receptors. So estrogen is important for manufacturing tears. It varies the depth or your cornea, basically. So what often happens in perimenopausal women, so in the ages of sort of 30 to 40, a lot of people will go through prescription changes very rapidly. And that's actually because of declining estrogen. And so if we were to able to give that person estrogen, they might not have to go through so many rapid changes of glasses, which are very expensive. The other thing is what we can see here is all the groups of things. So we know GSM, which stands for genitourinary syndrome of menopause, that can actually be fatal. So if you have a woman in her 60s or 70s who has an undiagnosed or unrecognized UTI, ends up in hospital, and that can have a significant effect on that person's quality of life or lifespan. And that as a result of a decreased estrogen in the vulva. So it's not just that you get vaginal atrophy or pain or pelvic pain, but it's actually that you can get increased recurrence of urinary tract infections because the vaginal microbiome changes with the lack of estrogen. And that then predisposes to things like thrush and bladder infections, which can be terrible for quality of life. Then we have the musculoskeletal syndrome of menopause. So that would be basically just increased body pain everywhere. Estrogen is responsible for the laxity of our tendons. So very interestingly, in female athletes, they've found that they are more likely to injure themselves while ovulating, because their tendons tend to be more supple. So they have a rolled ankle or an injured joint over ovulation. And so they tend to actually not overwork themselves during that part of their menstrual cycle. And it's because of estrogen. And so what we find in perimenopausal women is they'll often come with hip pain or shoulder pain or just generally increased body pain. And then a big one, which is very distressing for a lot of people, is weight gain. So as estrogen declines, insulin resistance gets worse. And that is why your body gains weight, because what adipose tissue does is adipose tissue makes estrogen. Unfortunately, it's the wrong type of estrogen. So it is E1, which is not particularly good at doing the job of E2, which is the real biologically active estrogen. But your body tries to overcome the fact that there's an estrogen deficient state by gaining abdominal fat. So that is something that often happens very early on. And then the classic sort of perimenopausal symptoms of hot flushes and night sweats, only about 50% of people report these. So very often, if you're only doing the sort of famous symptoms, you will miss patients because it doesn't happen with a lot of people or everyone, only half of them. An important part of your history taking should also be the family history. So there is a very strong genetic component to this. If you can ask someone about their siblings or about their mom and what age they went into menopause, it's very common that it will be a similar age. The big issue with that is that very often people's moms don't know when they went into menopause. The generations above us were kind of like, oh, I didn't really notice, we just got on with things. And it's something that we see very often. But if that information is available, it can be very useful. And then another important part of the history taking would be to see what has that person's experience with hormones been in their life previously. So patients who have had a history of postpartum depression, for example, are at much, much higher risk of experiencing depression during the menopausal transition as well. And the same goes for patients who have a history of PMDD or premenstrual dysphoric disorder, which is something that we see in the neurodivergent community a lot. About 95% of women with autism have premenstrual dysphoric disorder, meaning severe depressive symptoms throughout their luteal phase. So patients who have struggled with PMS, maybe they had a really difficult time during puberty, these are the patients that are also going to really struggle during perimenopause. So having that kind of history gives you an idea of what they're going to be in for. And this is because estrogen is dopaminergic, it is serotonergic, it affects GABA, it affects insulin. All our hormones work all together with our neurotransmitters. And so this is why perimenopause is actually a neuroinflammatory state, which is very unpleasant. All right, so what other workup do we want to do on this patient once we've taken a history? And this is a really big thing, and it's something that I see all the time in my practice, and that is someone who has been told that their bloods are normal, and so they're not in perimenopause. So they went to someone and they said, I think I'm in perimenopause, and so we did a test of estrogen and progesterone, and it comes back as normal. But the issue is, what is normal in the face of hormones? So we know that if we really want to get a proper snapshot of someone's menstrual cycle in terms of their progesterone levels and their estrogen levels, we test it on day 21. So we test it 1 week post-ovulation, because that is when progesterone is highest, and it should be highest if that person has ovulated. And if the progesterone is low, we can say, okay, you had an anovulatory cycle. And that's generally what the testing that we do is for. It's actually for fertility, to see if that person is ovulated. But this doesn't give us any information for perimenopause. Firstly, because that progesterone might be normal, and we know that the reference ranges for things like estrogen and progesterone are really huge. So estrogen's reference range can be normal between 200 and 1,500, which is a really big reference range. But we don't know what that person's estrogen was like when they were 25 in comparison, for example. So it might have dropped off since then. The other thing is that hormones are not that simple. We know that there was a study that was done that showed that progesterone can have a rise and fall, so peaks of troughs of up to 6 times in an hour. in one patient that was studied. So you can have a rise in estrogen because you go outside and you smell something nice, your estrogen can raise. So when we do bloods like estrogen and progesterone, we're really just looking at a snapshot of what was happening to that person in the minute, but it doesn't tell us about what's happening overall. And by its very nature, perimenopause is erratic with hormones. Our estrogen goes up and down all over the place. And so giving bloods really doesn't help. What we want is we just want symptoms. It is a clinical diagnosis based on symptoms. When we are working up this patient, we also need to find out if the patient needs contraception. So this is kind of where it becomes sometimes a little bit tricky, because if they need contraception, unfortunately, menopausal hormone therapy doesn't provide contraception. So you can still get pregnant on menopausal hormone therapy. So if you are starting patients on MHT and they are still at risk of getting pregnant, and the way that I ask that with my clients is, are you currently having sex with someone who has a penis, who has sperm? All right, because not everyone is doing that. But if they are doing that, then they're at risk of pregnancy and you need to have this conversation. And as we always say, that vasectomy is the best option. So if that is an option for your clients, it really is something that you should be talking to them about. And we'll go back to that a little bit later. Do we need to do screening tests for these patients? Does a patient need a mammogram? Well, this depends on their history. So essentially, the only real absolute contraindication to MHT is a personal history of breast cancer. So someone who has been diagnosed and treated with breast cancer. And I'll go in a little bit later. So obviously those patients will need to be counseled, and we'll talk about that. But if a patient doesn't have any personal history of breast cancer, they do not need a mammogram in order to start MHT. So you don't need a clear or negative mammogram, mostly because this would not be feasible if we think about resources. But a good breast examination, making sure that there's no obvious lumps or bumps, we don't need a mammogram. If they are high risk, so there is a genetic component to it, where a patient might have a family member or they've done genetic testing, it might be a good idea. But when it comes to menopausal hormone therapy and breast cancer risk in terms of family history, that person will always have a high risk of breast cancer because they are genetically predisposed to it. But menopausal hormone therapy does not increase the risk of that person having breast cancer. So they should continue to follow the normal guidelines of when they are told to go for mammogram. So if they're supposed to go for annually or every 5 years, they should continue on with that, essentially. We are seeing a lot of move to people doing sort of like intervention or prophylactic colonoscopies. Technically, a colonoscopy or screening colonoscopy is indicated in a patient who has a family history of colorectal cancer or who has a long-term history of gastrointestinal disease. So if they've had inflammatory bowel disease or irritable bowel syndrome, they might be a candidate, but not everybody needs to go for a screening colonoscopy. Pap smears. So if a patient has a bleeding from the vagina of unknown origin, that is also a contraindication to menopausal hormone therapy. So you would obviously need to work that patient up first, and hopefully we would do that. But a pap smear, a normal pap smear in the last sort of 5 years is absolutely fine. Currently, SASOG's guidelines recommend a pap smear every 5 to 10 years in patients who are low risk. So someone, example, who has had the HPV vaccine, someone who doesn't smoke, someone who doesn't have HIV, someone who maybe does not have multiple sexual partners, those people would be considered low risk. And so they can have a pap smear every 5 to 10 years. But it obviously would be dependent on the person sitting in front of you, whether or not they need them right now. So DEXA scanning or bone density scanning. So this is not important in terms of needing to do it prior to MHT, because we know that what we're doing with MHT is treating for osteoporosis. So if you go for a DEXA scan and you see, okay, your bone density is quite low, what are you going to do to treat that? Okay, well, we're going to start estrogen to treat that, and we're going to tell the person to do weight training or to do resistance training to improve their bone density. So I always say, if we're thinking about wanting to do an investigation, what are we going to do with the answers from that investigation? Well, we're going to recommend the same thing that we would do even without it. So yes, it might be important to know the patient's risk. So they might need to know their full risk. but we're going to encourage all of these patients to work on their bone density anyway. So there are certain guidelines about DEXA scanning. I'm not going to go into the very details of that, but it is not an absolute necessity to do that before starting MHT. Part of our history should also be looking at things like, do they have a history of cardiac disease and osteoporosis? And if they do, it gives us even further information that we actually want to institute MHT because it is preventative for these diseases. And then we want to treat our patient holistically. So we want to make sure we're not missing some other disease. They don't have hypothyroidism. They aren't looking at something like a vitamin D deficiency, which can cause fatigue or iron studies. This is kind of what I would normally do for this type of patient. The reason that we test cholesterol, well, cholesterol is converted into estrogen by the liver. So if our patient has a very high cholesterol, it tells us that potentially the patient isn't making estrogen from all of that cholesterol. And we want to be able to follow that baseline as we go along with the patient. So we should always do a fasting lipogram with these patients. Right. So I spoke about it a little bit before, but what are the contraindications to MHT? Like I said, the only real absolute contraindication is a personal history of breast cancer. But these patients, and if you go and read about it, if your patient has a personal history of breast cancer and is now in remission, for example, and they have severe menopausal symptoms, that person deserves to be counseled and to be given all of the information so that they can make a decision for themselves. So I have 1 or 2 patients like this who have a personal history of breast cancer, but their menopause symptoms were very, very extremely severe. And they made the decision to go on to menopausal hormone therapy and risk it because their quality of life is so much better. And then you would just make sure that your follow-up with those patients is very good, and so that they can make those decisions for themselves. They have that autonomy to do so. There have been, unfortunately, very limited studies in this, but a couple of the studies that have come out have shown that if there is a recurrence of breast cancer from MHT, it generally tends to be a very treatable version of breast cancer. So that is quite reassuring, at least. And then obviously, if the patient has unexplained vaginal bleeding, we need to work that patient up before. And then you'll see I put thrombosis ? So in the IMS guidelines, it says that if a patient has a history of thrombosis, that is a contraindication. However, if you're using transdermal estrogen, there is no reason that that is a contraindication. So if your only access to MHT is an oral estrogen, then you cannot give that to someone who's had a DVT or stroke, but you can give them transdermal estrogen. It's absolutely safe to do so. So that is not actually a contraindication to menopausal hormone therapy. And then porphyria is one of the contraindications, which thankfully is quite rare, but you should be asking about it in history. All right, so we have taken our history a bit further with our patient, and she tells us that her sister sounds like she is in menopause at the age of 46. So if we say that symptoms can start of perimenopause about 10 years before menopause happens, this is definitely feasible for this patient. She recently went to an optometrist and noticed her eyes get blurry for no reason and told that the #1 cause of blurry vision in women her age was perimenopause, but she wasn't sure about that. So like I said, estrogen affects tear production and corneal thickness. She has also noticed decreased vaginal secretions or arousal during sex, and she has become intolerant of caffeine and alcohol, which makes her extremely anxious. So there is an estrogen influence on the liver production of ADH and gut motility, which can affect alcohol metabolism, amongst other things with aging. She also finds herself struggling to remember words for things and has been feeling particularly irritated with her partner in the 2 weeks before her period. And this just goes to talk about estrogen with serotonin and dopamine. She started to experience hip pain, which she's been to for the physio, but we can't find any reason for the hip pain, for example. Her periods are unchanged and regular. Her blood tests come back within normal ranges, and we do not find any evidence of any medical conditions. And so we can say almost for certain that this person's experiencing symptoms of perimenopause. So what are we going to do? We are going to talk to and educate the patient about her choices here. And this I have described as the gold standard of menopausal hormone therapy, which is the body identical menopausal hormone therapy. And this is basically just what a script would look like, for example. So we're going to choose an estrogen and a progesterone. And the estrogen that I would recommend that we choose is the transdermal form of estrogen. So transdermal estrogen rubs onto your thighs, immediately absorbed into your bloodstream. There is no risk of thrombosis with transdermal estrogen at all, and it has very good reduction of symptoms. It is relatively inexpensive. A bottle of Femigel is about 300 Rand. It is covered by most medical aids. So medical aids will cover one estrogen and one progesterone. And the nice thing about it is that you can titrate it to effect. So you can start at one little pump. It comes in like a little aerosol can. It's an alcohol-based gel, and you can go all the way up to 4 pumps with that, and it's just according to symptoms. So you keep adding until all your hot flushes are going away or you start to feel better. All right. And then vaginal estrogen. So the reason we give vaginal estrogen is for our genitourinary syndrome of menopause. So patients who are really struggling with vaginal dryness or bladder infections or thrush, this is where you really want to prescribe vaginal estrogen. There is some cover for this with the transdermal estrogen. So some of the symptoms might get better with the transdermal estrogen only, but the vaginal estrogen is really where this comes into play. And what's very nice about vaginal estrogen is that you can prescribe this for anybody. So they don't have to be in perimenopause. Any patients who are struggling with recurrent UTIs or dryness, it works very well. Even patients who have breast cancer can safely use vaginal estrogen. We use it in our trans male patients who have vaginal dryness as a result of testosterone, and it doesn't affect their blood levels of estrogen or testosterone at all. So vaginal estrogen is very safe and very effective for GSM. So that is how you prescribe it. And then we use the micronized progesterone, so that would be the utrogestan. Okay, and so when we talk about body identical, and I guess this is sort of like controversial to say so, that it's body identical, but it really is a real thing. So the progesterone and the estrogen that is made here looks incredibly similar to what our bodies or what our ovaries make. And so our bodies use them once they are in our body exactly the same way as they would with what our ovaries are making. So when your ovary normally secretes progesterone, progesterone is converted into allopregnolone, and allopregnolone binds to GABA receptors in our brain, and that makes us feel calm and it helps us sleep. And the progesterone that we ingest here, the utrogestan, does exactly the same thing. So it works in the same way. If you take a synthetic progestin, which is in Clara or hormonal contraception or any of those things, it doesn't do that. So it doesn't work the same way. The only way that you can treat perimenopausal symptoms of low progesterone, like insomnia and anxiety, is with a progesterone that looks the same as the ovaries, the one that our ovaries make. The only symptom that we treat when we give something like a hormonal contraceptive with perimenopausal, for perimenopause, like the synthetic progesterones, all that does is it manages the uterine lining. So very often and for a long time, it was thought the only thing that progesterone is good for is keeping the uterine lining thin and protecting it from endometrial hyperplasia as a result of the estrogen. But that's actually just not true. We get a lot of very good side effects from the progesterone that don't have anything to do with the uterine lining. So the gold standard is body identical micronized progesterone at night before you go to bed. And that is what we would start. Some people, especially in patients who are much younger, if their only symptoms are anxiety and some insomnia, they start only the progesterone first. So progesterone tends to start declining. It's one of the hormones that starts declining first before estrogen becomes erratic. So some people will say, okay, we can just start you on the progesterone first and then see how your symptoms progress, and we can add the estrogen in later. And then the fourth one is our transdermal testosterone. And so testosterone is not currently routinely recommended in any of the guidelines. It is specifically recommended for the treatment of something called hyposexual desire disorder, which is actually in the DSM as a psychiatric diagnosis. And we could go into the politics of that I could talk about that for hours, but essentially a long time ago, some people thought that if a woman declines sex and only wants sex once a month, there must be something wrong with her hormones, and so we must give her testosterone. We now know that it is a little bit more complicated than that. So there are multiple factors why someone wouldn't be interested in sex, and it doesn't always have to do with testosterone. However, if your patient is distressed at their lack of libido and they're struggling with their sex drive, prescribing a low dose of transdermal testosterone does or can work extremely well and is perfectly safe to do. So what we do here to save patients money is we prescribe androgel. So androgel is the testosterone that is used generally for cis men, and a cis man would use 1 sachet a day or 50 milligrams a day. It comes in like a little sachet that looks like a tomato ketchup sachet. And what we do is we prescribe that to women, and all they do is they just take a small amount out of the sachet. So you explain to them, this sachet would be used for a man, and they would use 1 sachet a day, but what you're going to do is the sachet will last you about a week, 5 days to 7 days. And you explain this is 50 milligrams, you only want to use 5 to 10 milligrams a day. And many of my clients, what they'll do is they'll take a syringe and they'll pour it into the syringe, or they'll put it into a little jar, and they figure it out. But the good thing about it is that it's very difficult to overdose. So a lot of people are very scared that they're going to become masculinized or they're going to grow a beard. I promise I work in gender affirming care. In order to get masculinized from androgel, it takes at least 3 months of using a whole 50 milligram sachet every single day. So that is not going to happen to your patients. Obviously, you want to screen to see can the patient understand your instructions. That's obviously very important. But that is what I recommend, because the androgel, for about 4 sessions or about 4 sachets a month, that's going to cost about maybe 300 Rand, maybe 250, 300 Rand. The Testafem, which came out very recently, I think at the end of last year, which was specifically designed for cis women, where they give, it's 10 milligrams per gram in the cream. That tube costs 2,500 Rand, or something like 3,000 Rand, and that lasts for 90 days. So it ends up costing over 1,000 Rand a month, compared to 250 Rand a month. So it has fallen to the pink tax, unfortunately. And so this is kind of why we recommend this as a nice way to save patients money, right? And so important part of menopausal hormone therapy is that you cannot only prescribe estrogen. So you cannot only prescribe the Femigel. You can prescribe only the vaginal estrogen. So vaginal estrogen is very low dose. That's very safe, that's fine. But you cannot only give an estrogen tablet or an estrogen gel. You do run the risk of causing endometrial hyperplasia and specifically potentially causing endometrial cancer. There are some studies going on about this, but at the moment, that's definitely one of the important things. If you're prescribing estrogen, you need to prescribe some sort of progesterone at the same time. And then you will see, might have heard of something called continuous MHT or sequential MHT. So what's the difference? Continuous would mean every day the person takes an estrogen and every day they take the progesterone. So it doesn't matter where they are in their menstrual cycle. And this was thought to kind of be working for patients who don't have a period. So we say, okay, we cannot sort of sync your menopausal hormone therapy to your period, so we're just going to take it every single day. But what often happens then with sequential, the idea is that you time it with your period. So you would say to the patient, okay, you have a cycle. What you're going to do is you're only going to take estrogen from the first day of your period until ovulation. And then the day after you ovulate, you take the progesterone as well. So you take the estrogen and progesterone, and then the day before you're meant to have your next period, you stop taking the progesterone, but you carry on taking the estrogen throughout. And a lot of people find this too difficult to manage. It becomes quite confusing and quite complicated. And if your patients do have erratic periods, if their periods are already getting irregular, this is almost impossible to achieve. So continuous menopausal hormone therapy, taking the progesterone and the estrogen every day, is absolutely fine to start in any of your patients if they're struggling with the sequential. That's why they have the brands like Everol Conti and Everol Sequi. That's all it means. So the Everol Conti has got the same estrogen progesterone in every patch, whereas the Sequi has estrogen in the first part of the box and then estrogen progesterone in the second part of the box. All right. Are there generics? So you'll see I've used the brand names here. At the moment, there are no generics. So these are the only brands that currently make the body identical hormone therapy. I spoke to the rep actually this week, and he says the generics are coming. So we're really hoping that there are going to be more brands that are bringing out the transdermal estrogen and micronized progesterone. And like I said, medical aid does mostly pay for this. Unfortunately, often they require a gynecologist to sign off on it to pay, which, if you really think about it, if we expect 51% of the population of South Africa to see a gynecologist to diagnose their menopause, that's going to be quite challenging. Like I said, this is supposed to be a primary healthcare concern, but medical aid should pay, and we have been filling out those PMB forms for paper. All right, so these are the things that patients will often ask, and some important side effects to notice. So firstly, with topical progesterone, so a lot of your patients might come and they say that they were given topical creams by another doctor from compounding pharmacies, and we do see this quite often. Topical progesterone, so progesterone in a cream or a gel, is very poorly absorbed. We see this all the time. It just doesn't work. And again, if you're not using the first pass effect of the progesterone, so if you're not swallowing the progesterone and it's not getting converted by the liver into allopregnolone, you're not going to get the benefits from the progesterone. So if you give yourself topical progesterone, all it will do is basically nothing, because the studies have shown that it is very poorly absorbed, but all it will do is just manage the uterine lining, basically, if you're doing that. And so the issue with that is a lot of the patches obviously have, like Everol, they have progesterone in them. Some people really like the patches, it really works for them, but generally topical progesterone is very poorly absorbed. And then I spoke about that already. So the micronized progesterone, synthetic progesterones, very different metabolism pathways, like I said. All right, side effects. Most common one that patients sometimes get upset about is that their boobs will get bigger. It's very important to tell them that, because if your patient's breast get bigger and you haven't warned them about it, they do get quite upset. So that's important to talk about. And they might also get quite tender in the beginning. And then some anxiety. So sometimes the estrogen, like I said, it's quite dopaminergic, quite serotonergic. So you can get like a bit anxious or a bit zoomy, basically, from the estrogen. The way I like to explain it to my patients is I say, okay, well, estrogen is very high when you ovulate. So that's what you're going to be feeling. So during ovulation, what does your body want you to do? Your body wants you to go and get pregnant. So it makes you horny, it makes your skin glow, it makes your hair look good, it gives you energy, it gives you increased self-confidence. That's what estrogen does. And that's how you can explain what happens to your patients. And then what does progesterone do? Progesterone is now preparing your body for pregnancy. So it makes you tired, it makes you sleepy, it makes you chill. It does increase your cravings for sugary foods. So that's one thing to keep in mind, like when you are in the luteal phase, it's going to do the same thing. So with progesterone, you might notice some water retention, some increased cravings, you might be a bit groggy in the morning, and you might have some bloating and GIT symptoms. And these, for the most part, go away after 4 to 6 weeks. So you can sort of prepare your patient that the first 2 months might notice some different side effects, but the majority of them go away after about 6 to 8 weeks. Unfortunately, a lot of people, not a lot, but there is a population that are just progesterone intolerant. So they'll take it, they'll feel terrible, it'll affect their mood, they'll feel depressed. And those patients are often neurodivergent patients, but they can be a lot of different people. So it's just important to keep that in mind. A big thing, unfortunately, is that people are very concerned about weight gain with menopausal hormone therapy. The data emphatically says that it does not cause weight gain, because essentially, if we think about the theory, estrogen increases insulin sensitivity. So actually, menopausal hormone therapy should help you lose weight, or at least not gain more weight. However, progesterone can increase your cravings for sugary foods and carbohydrates. So there is kind of like a balance there. And I have had some patients who have come to me and said that they feel like the MHT has made them gain weight. The sort of big thing there is, well, was it the MHT that made you gain weight, or is it actually your perimenopause itself that's driving insulin resistance and has made you gain weight? And so one or two of the other, but the studies specifically say MHT does not cause you to gain weight. All right, and then breast cancer, again, so there are competing studies when it comes to the breast cancer risk. If you read in the international guidelines, it will say that if patients are on estrogen for a long period of time, there is a slightly increased risk of breast cancer, but it is so slight that it does not warrant being concerned over, essentially. So the benefits far outweigh the risk of increased breast cancer. The WHI study, which was done in the early 2000s, which stopped everyone from taking MHT, was really very flawed and misinterpreted, and those patients were already at very high risk. And so there is a small risk of breast cancer, but it is not enough to say that you shouldn't take MHT, essentially. Appropriate screening is always the most important thing. And then, like I said, testosterone is currently only indicated for desire disorders, but there is some emerging evidence to come out to say that it does help with bone density, mood, and muscle mass, but that is still yet to be seen. And then a lot of people want to know, will I have the same side effects or symptoms as I did when I was taking oral contraceptives? And the answer is no. So a lot of people have had really bad experiences with oral contraceptives. They killed their libido. It made them gain weight. It made them depressed. Almost all of my neurodivergent clients have this experience with synthetic progesterones. And so that is why you can assure them that the gold standard body identical MHT does not have the same side effects as COCs. And as a result, therefore, does not cause contraception either. So you can get pregnant on MHT. You are still ovulating technically, especially if you still have a normal menstrual cycle, so you can still get pregnant. And then when it comes to monitoring, do we do monitoring of blood levels? No, we don't. So there is no specific estrogen level that we're looking for when we check if the MHT is working. So all we want is symptom reduction. That's it. That's what we're looking for. Does my patient come back in and say, I feel really good? Then you say, yes, cool. We don't have to worry about testing estrogen and progesterone. We can just manage the patient holistically, normally look at the rest of their medical conditions like we would normally. Okay. So for some people, the transdermal estrogen, the gel, and the micronized progesterone, they won't like it or they won't want to do it. And so there are other options, and you'll see there's a few options on the market. The patches are available, like I said, the Conti versus Sequi, but the progestins is not the same. It's not a micronized progesterone. It won't have the effects of helping with sleep and with anxiety, but it will protect the uterine lining. So I have maybe 1 or 2 patients who prefer the patches over the gel. Sometimes it has to do with a sensory thing. They don't like the rubbing the gel on them. Oh, keep in mind something I forgot to say. With the estrogen and testosterone gels, you should warn the patients that it must be dry before other people touch them, specifically children or animals. So if you rub estrogen gel onto your thighs and then your kids come along and they touch it, obviously it can be absorbed through their skin. So it's just something to keep in mind. Right. There is Formostin, which is dihydrogesterone. That is an option as well. It is slightly more similar to micronized progesterone, but still not the same thing. And any oral contraceptives, any oral estrogen is going to have a markedly increased risk of clots. So DVTs and so on. We all know we shouldn't be giving oral contraceptives to patients sort of over the age of 35 or 40 because of this increased risk, especially if our patients are smoking and have other risk factors. So the pill works very differently. And you might find these patients will come in with symptoms of perimenopause and they are on oral contraceptives. It happens all the time. And you think to yourself, but how is this even happening? Aren't the hormones kind of like masking it or covering it up? And sometimes they are, but especially that progesterone drop, they will still feel it because the progestins that's in the oral contraceptive won't work the same way. Whatever you do, and I made this mistake with that first patient with the frozen shoulder, whatever you do, don't tell that patient, okay, let's stop the pill and see if you are in perimenopause. because they will have the worst month of their life and they will be very upset with you. So if a patient is on oral contraceptives and they're starting to have perimenopausal symptoms, we just move them over. So you stop taking the pill the one day, and the next day you start taking the MHT, and you might feel a bit funny. So in the first couple of weeks, might have some symptoms, but you can move over quite smoothly. But don't just stop the pill. If you're having menopausal symptoms, they will become much worse, essentially. All right, compounded creams. Some people don't like the Vagifem pessary and they prefer a cream. It's really just individual preference. So you can get vaginal estrogen creams from compounding pharmacies like Fagron that you can look into. Unfortunately, with compounding pharmacies, there is really no way to quality control what you're getting in that product. I have a few patients who use compounded medicines, and sometimes they do notice a sort of difference in batches and so on. The problem is just quality control. We don't really know what's in those creams, but sometimes there are. Yeah, it's up to you essentially when it comes to that kind of thing. I just want to mention one supplement. So the Agnus castus supplement, or the chasteberry tree extract. If your patients tell you that they're using this and that it's helping, it is actually very evidence-based. So it's actually in the British menopause guidelines, and patients who are not able to take MHT if it's contraindicated. Agnus castus is a very well-known herbal supplement that helps patients with PMS, with PMDD, even with PCOS. It can help with acne. And it can help with mood changes and so on if in perimenopause as well. So this brand, that Kiko Health supplement brand, it's got this as the active ingredient. There's a couple of them that have it, and it does actually work very well. So if the patients are taking that, you can say happily that they can continue, and it is an option if they can't take MHT. And then you need to ask, well, this is the problem. If the patient needs contraception, and this is very often a difficult thing. Patients who have very heavy menses, we know that as perimenopause comes along and estrogen is very erratic, they can have really heavy periods and have iron deficiencies and they're bleeding for 2 weeks and the quality of life is really affected. Those patients, we can recommend something like an intrauterine contraceptive device, like a Mirena, like a Kyleena, if it's possible. If they're young, like they're 40, and they're still going to be having a menstrual cycle for potentially another 10 years, the Mirena is a really good option, because then you're managing your symptoms of perimenopause with the MHT, and you're saving the person from bleeding to death every month. And you're preventing pregnancy. So it's a really good option. Oral contraceptives are just essentially very high risk, and they're not always going to make the difference that you want with the symptoms. So it's just something to keep in mind. And like I said, vasectomy is, if they are heterosexual, a very, very good way to go about preventing pregnancy. If that person has completed their family, or if they know their partner and them they want to remain child-free, it is a very important conversation. Vasectomy costs, I think now, between 12 and 15,000 Rand. If you're on medical aid, it is totally covered by medical aid, except I think the initial consult with the urologist. To give you an idea, Mirena costs 4,500 Rand, and then you still have to have the insertion, and that's only for 8 years, or 5 years if your periods are very heavy and you're in menopause. So it's just something that you need to have the conversation with. Whenever I have a conversation about contraception with my patients, I just tell them, unfortunately, as a person with a uterus and ovaries, there really is, it's about kind of being in between a rock and a hard place very often, but we want to prevent pregnancy. So it is quite a difficult conversation sometimes. All right, and then just because this is really important, yes, estrogen and progesterone really helps, but it is going to be a band-aid on top of a bullet wound if we're not also looking after ourselves, unfortunately. So two most important lifestyle interventions that every single person, regardless of gender, needs to do. They need to pick up heavy things and put them down again. Unfortunately, Pilates, I'm sorry, does not count as this, all right? It needs to be progressive overload. You need to struggle. Your bones need to be under tension and stress so that they can get tiny little micro fractures, and that's how they get strong. Again and again, we are seeing evidence that shows that having increased muscle mass on your body, particularly in your thighs and your butt, is associated with longevity and health. So you need big, strong legs. And you know what else happens when you lift weights? Your muscles secrete brain-derived natriuretic factor. that increases your, decreases your risk of depression, increases your cognition, decreases your risk of dementia. So please pick up heavy weights and eat protein as much as you can. I always just say to patients, you don't have to be perfect, but if you're trying to get some protein in 3 times a day, that'll be really excellent. And then supplements, people always ask about supplements, especially if you work in private. The only supplements that are evidence-based are those 4 that I've written there. Every single person should be on creatine. So 5 grams a day is for the muscle benefits, but 10 grams a day has repeatedly been shown to be very important for cognitive benefits. It can be any creatine, the cheapest one on the shelf. Don't buy ones that say specifically for women. There's no such thing, all right? And then your omegas, your magnesium, and your vitamin D. And the omega-3 is obviously very good for keeping your cholesterol in check as well as an HDL. And then if your patients are struggling with any painful sex, pelvic dysfunction, urinary incontinence, constipation, anything to do with their pelvic floor, please send them to a pelvic floor physiotherapist. It is an underutilized multidisciplinary team member. They can work real wonders. Very often, women were brought up to keep their knees together, keep their everything tight. Some people are tight up here in their shoulders, but a lot of people are actually tight in their hips and their pelvis, and this can cause a lot of issues in their lives. So you are far more likely to have an overactive and too tight pelvic floor than have a loose pelvic floor, which everyone is always so worried about. So please, if your patients are experiencing any of those GSM symptoms, they should also be sent to a pelvic floor physio. All right, so now that I have info dumped on you, I just want to say the take-home messages, essentially. So something that I've been seeing again and again when I go to talks is people saying, oh, people come in and they see these things on TikTok, they see these things on Instagram, and now they think, oh, it's happening to me. And I understand a lot of the stuff that people are seeing, or we are seeing, is misinformation and it is wrong. But it also means that for decades, we as doctors have been gatekeeping all of the information for ourselves. And the only way you could access this was coming to speak to us, and we would give you the information. Those days are gone. If you go onto the internet, you can download the latest guidelines yourself. You don't need a medical degree. You can research and study everything you want about your own medical conditions. People are able to advocate for themselves. They have better agency, and it is actually quite wonderful. But it does mean that we as doctors have to up our game a little bit, and we also need to believe people. So many women have come into my office to say that they've seen so many doctors who've told them that what they're thinking about is just in their heads, that their bloods are fine, that nothing is wrong with them. And so they come into my office ready to fight for themselves. And so just listening and saying, I agree, and I'm sorry that that's happening to you, can really just change the entire atmosphere of your practice. And so when I say that we diagnose perimenopause through just by listening and believing women, I really do believe that. I really recommend that. So we know that, unfortunately, when we talk about evidence-based medicine, only the conditions that hopefully will make money for the people who are doing the trials get funded. And so there have been a lot of areas of medicine that have been neglected, and hopefully now this is changing. And a reminder that cis women were not included in medical trials until very recently. Again, managing perimenopause is a primary healthcare concern. It should not have to be managed by specialists. Half of the world's population are going to go through this. And again, the only current absolute contraindication for menopause or hormone therapy is a personal history of breast cancer. And those patients can still be counseled and be given the gift of informed consent for their quality of life decisions. So at the end of the day, MHT is the first-line treatment for genitourinary syndrome of menopause, musculoskeletal syndrome of menopause, vasomotor symptoms like hot flushes. It prevents cardiac disease and osteoporosis and has very little risk. The gold standard is body-identical estrogen and progesterone, and adding testosterone is feasible and safe. But care should always be individualized as much as possible. Gaining muscle mass is the best thing every single person can do to improve their health, so please go and squat. And just out of interest, that case study was actually me. I started on HRT 2 weeks ago, and I am feeling much better. So estrogen is coursing through my veins and allowed me to have the energy to create this presentation. So that is everything I have to say. My references are here. Like I said, I mostly use the International Menopause Society, and then some of the studies that I spoke about are here. There is a wonderful Spotify episode by the Neurodivergent Women podcast called The Menopause Transition, which is a really nice thing to send to your patients and to listen to as well. And then the British Menopause Society has a great website where they have individualized or little chapters, which you can read, tools for clinicians about every single thing that goes into managing menopause. So that's a very helpful site as well. And that's me. And I've gone well over time.
Thank you very much, Robyn. I think, shall we go to the questions? There are a couple in the chat.
I'm so sorry, I didn't see the time. You should have interrupted me.
No, I was hanging on your lips.
Okay. So I'm going to stop sharing now. There we go.
Would you like me to read the questions to you, or do you want to go through them?
Using the chat. Okay, should I just start at the top?
Yeah.
Okay, the value of progesterone only versus combined ACLS. So essentially, basically, I would say the value of progesterone only would just be based on the patient's symptoms. So if the patient's very clearly only having low progesterone symptoms, which you can often see, someone will have, maybe they've gotten worse PMS symptoms just before their period, like, that week and so on is getting really bad. They're having really a lot of anxiety. They're struggling to sleep. Then you can do a trial of progesterone, but there is no real, it's just one of those things, almost like it's like, oh, you could try it and see if the patient does better. Yeah, that's an interesting question. I think it really just about managing the patient's symptoms, because estrogen can sort of be a little bit anxiety inducing sometimes if you have too much of it. So starting with progesterone only can be an option. I'm not sure if I've answered the question. Okay, if a woman has had endometrial ablation, so that's a very good question as well. So that endometrium can still grow back, from what I understand. But you always, when you give estrogen, I haven't heard that, that precludes people from not getting progesterone. So the rule is, if someone gets estrogen, they must have a progesterone at the same time. So that's my answer that I'm going to stay there with. But what's nice is then they just don't have bleeding. So that's very nice. Any expected side effects from MHT from those with prior history of sensitivity? Yes, absolutely. So, and this is a big thing. So some people are extremely neurosensitive to progesterone. We see it in our neurodivergent cases all the time. So people who have PMDD is a neurosensitivity to progesterone. So those patients, I always caution, if you've had a really bad time in any high progesterone state, like you said, during pregnancy, you can sometimes then have symptoms as a result of the micronized progesterone. It's not something that I see all the time. I would say 90% of the time there's no issues, but you do want to caution to say, if these things are coming up for you, please come back so that we can try a different option, basically. All right. If the patient has underlying endometriosis and has been asymptomatic, but after starting HRT gets symptoms again, can they try to taper the estrogen? Okay. So yes, so there is some theory that giving extra estrogen can worsen endometriosis, the endometrial lesions. You can taper the estrogen or stop it, but eventually what's going to happen is those endometrial lesions are going to go away when they go through menopause. So this is kind of like it is a difficult space to be in. What you might find, if that patient is mostly pelvic pain or uterine pain, a Mirena might be a really good option for those patients to start with. But we know that endometriosis is a whole body condition, so that is sometimes difficult. But if you're giving the progesterone along with the estrogen at the same time, there shouldn't be such a huge response to it. I'm not entirely sure about that one. I'll have to think about that a little bit, but I haven't had that personally yet. All right. Can you use weekly SC? Right, so this person is asking about the estradiol valerate. So estradiol valerate is the estrogen we actually use for our trans femme patients. I have one patient who is using that at the moment who went through surgical menopause and is getting really good benefits from that. And that actually raises a really good point. Some people have very poor absorption of estrogen through their skin. So hypermobile patients, which is 70% of your neurodivergent patients, some people's skin just doesn't absorb very well genetically. And so if they are noticing that they're still having estrogen symptoms, even when they're maxing out on the Femigel, switching to the estradiol valerate, I think, is a perfectly good option. There's no reason why it would be dangerous to do so. So I think it would be good. Whether or not it would be first line, I'm not so sure about that. I don't think the evidence exists. Basically, we don't have the data with that. When would you discontinue? You never discontinue. So once you start on menopausal hormone therapy, you take it every day until you die. You don't ever discontinue it. This is kind of outside of the scope of this talk, but essentially the guideline at the moment says that you shouldn't start MHT more than 10 years after the patient has gone into menopause. So if the patient started menopause at 51, you have to start MHT before 61. And the reasons are essentially that the person has been in a low or an estrogen deficient state for a really long time. Their blood vessels have hardened, their tendons have hardened. It's a sort of like damage has already been done kind of issue. And we have seen, that's actually the WHI study looked at patients like that, where they gave estrogen to people who had already been in menopause for quite some time, and then they had cardiovascular complications. And so you want to start as soon as possible. You don't want to delay, and you want to continue MHT for a long time until the patient dies. All right. How many years are you aiming? Well, yeah, so you always use forever. Okay, there's no reason to stop at all. When would you consider prescribing DHEA? Well, that is a very long conversation. It's not currently in any guideline for anything. The benefit, I know that a lot of people are talking about vaginal DHEA. At the moment, there is currently no indication that I'm aware of. But that would be, I think, a sort of like special cases. We'd have to do a whole another talk on that, basically, but there's no current evidence or data for its use that I'm aware of. I may be wrong. Input on tibolone. So that's a bit complicated, but it is essentially, I went to a talk by Malika, I can't remember her surname, but she was one of the past presidents of the South African Menopause Society this past week. And she said, tibolone is menopausal hormone therapy. It counts as the same thing. Would it be an option to consider if you're going to add testosterone, so it's 1 tablet instead of 3 meds? Sure. Ria, I'm very sorry, but I'm not going to be able to answer your question. I don't have enough information about tibolone. I have never had to use it as yet. None of my patients have required it, but it does count essentially as the same as MHT in that it has all the same contraindications. So that's the only thing I can say about that. I'm sorry. Yes, there will be a recording. It's going to be on YouTube. Okay. Would you recommend MHT to perimenopausal women who are still planning for a family? So it doesn't seem to impact fertility at all. If you're using continuous MHT, so the patient is taking progesterone and estrogen, it can make your periods erratic. So it can make your periods less regular. So if the patient is trying to conceive, I would recommend that they stay on sequential. But I know very few patients who are trying to conceive and also on MHT, but it definitely it shouldn't affect fertility in that way, especially if you're using it sequentially. All right. Activol and estrogen. So essentially, exactly like I was saying, oral forms of estrogen are very high risk for things like clots. And it was very interesting because I looked into this also when I was for my gender affirming care patients, my trans patients. Oral forms of estrogen have a bioavailability of about 5%. They are very ineffective at raising your estrogen. And so I don't believe that they are particularly helpful. And I've had multiple patients come in who are on these medications already and still having florid menopausal symptoms. So the issue here is not that the medications are wrong. The issue is that the medical aids are approving the medications that don't work. And so you can try it. Absolutely, it is an option, but if your patient's symptoms are not improving, it might be because of the form of estrogen. And you have to counsel those patients. If the patient is 50 years old and taking oral estrogen, there is a risk of DVT. Okay. MHT should be discontinued if a woman develops a contraindication like breast cancer. Yes, unfortunately. Absolutely. So if the patient has to go onto tamoxifen or have chemo, then they would have to stop, unfortunately. Yes. Oh, did I get to the end? Those are very complicated questions. I'm sorry that I didn't. I will have to go up and read about DHEA and Tableau. It's just not something that we see every day. It's I think that's kind of where like the menopause specialists and so on would become important. But yeah, unfortunately with DHEA, there's just not a lot of evidence to support its use.
Good. Thank you, Robyn. You handled those questions very well. And also thank you for an excellent and really very practical presentation. And thank you to everyone who joined us this evening. We will submit this for CPD points. And then also I want to ask, as this webinar series grows, we'd love to draw on your expertise within our primary care community. So if you have a special interest, area of expertise, or topic you'd like to present in the future, and you're brave like Robyn, please feel free to contact me. I'll post my email address in the chat shortly. And then we have some very exciting talks lined up. I can quickly just share the ones that are coming. And yeah, so the next one will be on the 23rd of July. Just wait for this to show. That one was for today, and then our next one on the 23rd of July. And a very exciting one for the 27th of August is Dr. Yassine Khan from EM Guidance. He's going to take us through the future of digital healthcare. That should be exciting. And then Dr. James Porter will do point of care ultrasound in primary healthcare on the 17th of September. And then Bev Schweitzer will talk about functional neurological disorders. And then we'll have one more in November before we stop for the year. Yeah, so I just want to thank you all again for joining us, and a huge thank you to Robyn. Thanks.
It's my pleasure. Thank you. Thanks so much. And thank you for staying on even though I went so over time. That's very kind of you all.